Good evening, everyone. Gives me immense pleasure and honor to be part of ACPCon as always. Thank you, Rajada, for the call. And I thank the scientific committee for giving me a topic like an undiagnosed pleural effusion in 2020, because this is one of those topics where it's still work in progress. And when I say this, I mean that we do not have a unified definition of what is undiagnosed pleural effusion. I propose to organize my talk today as when is pleural effusion undiagnosed, which tests or tools are available to us, and at the end I would be presenting two case studies where undiagnosed pleural effusions were ultimately diagnosed. So how do we define an undiagnosed pleural effusion? Like I said, there is no universally accepted definition for an undiagnosed effusion. The reason mostly being that the facilities available in diagnostic centers or hospitals or departments vary considerably. I might have a thoracoscope, whereas the other center may not have. And what is undiagnosed diffusion to the other center would not be an undiagnosed pleural effusion in my center if I could get a diagnosis from a thoracoscopic biopsy. So to me, if a pleural effusion persists after the initial diagnostic workup, I would call it an undiagnosed pleural effusion. And again, that phrase, initial diagnostic workup, is variable and varies from one center to the other. From what I see in my clinic, the number of undiagnosed pleural effusions would be somewhere around 25% of the patients with pleural effusion. When does a pleural effusion remain undiagnosed? Yes, inadequately investigated. And when I say inadequately, I mean investigated with whatever tools are available in that particular center. For example, sophisticated tools may not be available. And I think most of us here in the ACPCon who practice to a little bit in the periphery of Calcutta or West Bengal do not have access to any sophisticated tools at all. So we have to depend a lot on clinical medicine and try and unify all the parts of the investigation reports in order to make a diagnosis. The performance characteristic of the test selected may not be the best, and sometimes we all have gone through these situations. We need to test pleural fluid repeatedly to see if malignancy is present or not. What are some of the common causes of an undiagnosed pleural effusion in our setup? Malignancy, like I described before, tuberculosis, anaerobic fungal infections, and anaerobic infections of the pleural space. I put it down here because I'm sure in the audience we have many people who has to give an empiric anti-tubercular therapy to patients based on a diagnosis of undiagnosed pleural effusion, because most of the time we do not get the facility to isolate tubercular granulomas by doing a biopsy or getting sophisticated imaging done. So empiric ATD, I know, is not a very sought after thing to do, but nonetheless, it has to be practiced in the rural portions of the state. Occupational exposure, you need to have a very strong hunch about what the pleural diffusion is about. If you have calcified lesions in the pleura, asbestos exposure is sometimes, we need to go on taking history from the patient's family to understand if they really had some asbestos exposure or not. Pulmonary vascular disease is one topic which we tend to neglect often. But believe me, if we looked harder, we might find a lot more pleural effusion being attributed to pulmonary vascular diseases such as superior vena cava obstruction or pulmonary embolisms. Autoimmune and connective tissue disease, I put that down here in the list because we have seen and we continue to see autoimmune diseases or connective tissue diseases, which instead of presenting with the classical joint symptoms or maybe uveitis or something else, they present with pleural effusion on the first presentation. Chronic abdominal pathologies like pancreatitis or abscesses anywhere in the abdomen, like a subphrenic abscess, maybe a liver abscess, or even a splenic abscess, pseudocysts of the pancreas. So any inflammation which is going on in the abdomen can give rise to pleural effusions, and it sometimes becomes imperative that we do a whole body imaging to find out where exactly the pathology is. We tend to miss out on ovarian hyperstimulation syndrome, but we should make it a practice to ask each and every female patient who presents with pleural effusion whether or not they are having some treatment going on in the gynecological department. What are some of the tools we need to diagnose pleural diseases? These may not all be available in our centers, but these are the desired ones. First and foremost, something that has been going on for ages. Light described the criteria in the year 1972, and henceforth there has been lots of criticism, but even today we followed Light's criteria of partitioning pleural fluid into exudates and transudates. Ultrasonography has recently been added to the armamentarium. It's indeed very useful, and sometimes the investigation of choice when we cannot aspirate blindly like we used to do in the past. In fact, ultrasonography guided aspiration is recommended in books these days as the method of choice. We can estimate the volume of pleural fluid remaining, and so so ultrasonography may help in monitoring the patient. CT scans, yes, to look at the underlying lung parenchyma. And sometimes in CT scan, we are able to find pleural nodules or pleural thickening portions, which we can do a CT guided or imaging guided biopsy to see what the tissue uh, actually is. PET CT to look at, like I said, to look at foci elsewhere in the body. I know of a medical doctor who had presented with nodules in the spleen as a part of a routine investigation. And then he had to do a PET CT to see if he had similar lesions elsewhere in the body, and which he did. And then he could do a biopsy from one of those lesions, and lo and behold, he had tuberculosis. MRI thorax is one of the new sophisticated tools which are sometimes used to diagnose pleural space infections. It can differentiate between transudates and exudates and empyema in a few of the studies that have been reported. And biopsy, yes, this is the golden thing that we have to do in order to make a complete diagnosis of the pleural effusion etiology. Biopsy, we used to do the blind biopsy before, but now due to the improvements in the imaging tools, we can do a CT guided or ultrasound guided biopsy, and even a thoracoscopic biopsy if we have the facilities to do so. I put this picture that just to illustrate that if you have pleural nodules like this might be very, very easily done. This might be one of the spaces where we can do a cutting needle biopsy. And in this particular patient, it was adenocarcinoma. So just simple CT scan, guided biopsy, a diagnosis can be made in few situations. So this brings me to my first case. It's of a 33-year-old male who presented with a history of sudden onset pleuritic right-sided chest pain for 2 days. He did not have any significant comorbidity, a young male patient. No associated fever, cough, no leg swelling, wheeze, no hemoptysis dyspnea, no weight loss, no anorexia, but he was a smoker and did desk job. He was a clerk in one of the railway departments. On examination, the vitals were stable, respiratory rate not too high, saturation 98% in room air, the typical findings of a diminished breath sound and in the right infrascapular area, no adventitious sounds, and systemic examination unremarkable. This is what the X-ray shows. So no doubt it's a right-sided pleural effusion because we cannot see the diaphragm outline and neither the heart outline next to the pleural uh, effusion. So what are the investigations that we did? Routine blood, which shows that it's normal urea creatinine and the electrolytes. ECG is within normal limits. So the first thing we said that to do in a pleural disease was to do a pleural fluid analysis. Protein was 6.5 grams compared to the serum, which was 7.3. LDH was raised. Glucose was 60 milligrams per DL. ADA less than 40, 25. Cellular counts were 400 cells with uh, I would say almost equal distribution of neutrophils and lymphocytes in this particular report. Ram stain and cultures were all sterile. CBNAT for Mycobacterium tuberculosis negative. There were no malignant cells. So pleural fluid analysis essentially showed us that it was a exudative lesion, exudative fluid that we had aspirated, but with a low ADA and moderate number of cells in the total count. Now, Light's criteria has been criticized for a long time, like I said before, because approximately 15 to 30% of the transudates are misclassified as exudates. And this is, like we all know, this is usually seen in patients who are receiving diuretics. Transudative effusions are mostly due to hepatic cause, renal cause, or cardiac cause. So in most of these, excepting maybe the liver cause, patients would be receiving diuretics in some form or the other. So when we see a exudative effusion in a patient who is supposed to have a transudative effusion, we have to keep this in mind. And because of the criticism, the analysis of protein and albumin gradients in these patients were suggested to accurately detect transudative effusion in these patients. So once this happened, we revisited the history. We tried to find out if he had any of that entire list of undiagnosed pleural effusion histories in this particular case. Malignancy, a young 33-year-old male, probably no. It could be one of these tuberculosis, anaerobic, or fungal infections of the pleural space, maybe one of the differentials. Occupational exposure, no, because he was a desk job and did not end up working in any of the railway workshops. Pulmonary vascular disease, we do not know. Autoimmune or connective tissue disease, he did not give any history of joint pains or eye involvement or any other system involvement. No chronic abdominal pathologies were detected or history suggestive of one of those. And a male patient would not have an ovarian hyperstimulation syndrome. Subsequently, very interestingly, the patient 48 hours later started complaining of severe left-sided chest pain in the night. The pain was non-radiating and was not associated with sweating, nausea, or even vomiting. There was no hemodynamic compromise or desaturation. And breath sounds reduced in both. The previous one was on the right side, but this time it is reduced in both infrascapular and infraaxillary areas. This is what, because he presented with the chest pain, we had to do an ECG. Essentially okay, no features of MI or anything. The chest X-ray has changed as expected by lateral pleural effusions, but we cannot see any uh, anything to suggest that the patient has a cardiomegaly or a heart failure. Later, he developed hemoptysis, a low-grade fever, Because of the hemoptysis and the X-ray picture, we did a D dimer, which was found to be 3.6, which was far above the normal range. So this is what the CTPA eventually showed. Filling defects in both the upper and lower pulmonary areas suggestive of bilateral pulmonary embolism. This is something very rare, but as you can see, it is nothing impossible. So this patient was treated for pulmonary embolism and he became symptomatic, symptom free, and was going and went home happily. So it's bilateral pulmonary embolism. So this patient was a 58-year-old female who presented with shortness of breath, which gradually increased over the past 1 month before he presented to us. Occasional chest pain and bouts of cough, which was essentially dry. It was not associated with any weight loss, fever, or anorexia, so nothing to suggest that she had a tubercular infection at any point of time. X-ray showed a loculated left-sided pleural effusion, and as was required, we did an aspiration analysis of the pleural fluid, which showed us the protein of 5 grams, albumin 2.6, LDH raised, glucose raised, ADA of 114 international units per liter, and only 100 cells with 80% neutrophils. Okay. There was no evidence of tuberculosis by both Zn staining or the PCR CB-NAT reaction. So when we look at the pleural fluid, it is quite obvious that it's an exudative fluid with neutrophil dominance and no microbial organisms, suggesting that the effusion was more an inflammation rather than an infection. So if the cell count would have been quite high in the background of an exudative effusion, we would have suspected some infection of some sort, but this is suggestive of inflammation and not any active infection. So we thought of revisiting the history of the patient, and when we asked her about the past, she said that she had been having a pleural effusion 1 year ago, for which she was treated for tuberculosis for 6 months. So we requested that she bring back the chest X-ray and treatment documents for us to scrutinize. This is how the old X-ray showed. A pleural effusion on the right side. So remember, we had the pleural effusion which was on the left side earlier, and this time it's on the right side. What did the fluid characteristics show in the previous admission when she was treated for tuberculosis? This is what it showed. And ADA was 48, LDH 175, glucose 40, 400 cells. Most of them were lymphocytes, and so she was given treatment for tuberculosis. Blood pictures were as expected, nothing fancy. So what we did was we did a ANA and ENA antibody profile, because after we found out that she had this almost alternating side of effusion, we were almost convinced that she had something other than a plain infective etiology. And when we looked at her papers, we found that she was on treatment of rheumatologist for Raynaud's phenomena. Joint pains came off and on. Mouth size, which was decreasing, and a feeling of tightness of the skin. So all of these are almost pointing towards one single unifying diagnosis of systemic sclerosis. So anti-nuclear antibody levels were raised, and they showed a dense, finely speckled pattern. Anti-Rho and anti-SCL70 were positive. However, the anti-La antibody and anti-centromere antibody tests were negative. So again, a clinical clue which led us to make the correct diagnosis. Systemic sclerosis, yes. So I would summarize here and say that the etiology of pleural effusion can remain obscure in around 25% of cases. Most often than not, a clinical clue is there in the history or the past records of the treatment. Other causes should be looked for, like a pulmonary vascular causes, connective tissue disease, like the other second patient whose first presentation was with a single pleural effusion and nothing, no other connective tissue disease symptoms were present. Of course, we had to go through the documents before we found out that she had Raynaud's phenomena. Occupational exposure, yes, asbestos is a very important one that we should never miss. And of course, ultrasound, CT guided imaging or thoracoscopy biopsies should be performed depending on the clinical situation and very importantly, depending on the availability. So that's it. Thank you very much. And I would be happy to take any questions if there were.